Thank you very much, and good morning, everyone. We are going to give a overview presentation, really, of our home support team, which we implemented just over, well, it's probably nearing 2 years ago now. It was mainly focusing around the care of patients who had been admitted to hospital with orthopaedic complaints, predominantly fractured hips. We'll go through and just let you know what we did. Just to let you know, I'm Janice. I've got Dawn to my right, who's one of the ward sisters in the area, our trauma and orthopaedic ward, and also we've got Sharon with us, who's head of occupational therapy, and Dave, who's one of our senior nurses as well, covering the area. One of the keys to it really was how multidisciplinary the approach was right from the outset, and we were able to get the benefit of our therapy teams and nursing teams working together to develop a programme. So really, we are a very rural health board covering a large landmass of West Wales, but as I say, predominantly rural healthcare delivery, and our area is Pembrokeshire, where we've got a rural population of 120,000 people, mainly elderly, and obviously during summer months as well, we do have normally a high proportion of holiday makers, which again can be a demand on the local healthcare system. So if we move on to, that's just some of our scenery, we move on to what brought us really to think about implementing this service. And it really started from us responding to a very high level of registered nurse vacancies and difficulty in recruitment. And we were finding that we were having a very high reliance on temporary staff, and where we could get them, it was sometimes difficult to retain them due to the geography, and with so many hospitals throughout Wales using agency staff, then it's quite difficult sometimes for them to travel as far west when they can get shifts nearer. So we had challenges in getting agency staff, and also even if we could, it's inconsistent and also high cost. So we wanted to look at what we could do to improve the experience of our patients and our staff really in this, particularly in the trauma and orthopaedic ward, and got some thoughts around particular groups of patients and helping them to reduce their length of inpatient stay and to carry on their recovery really in their own homes with the help of the staff that we would release to support them. So at this point we were leading on it as an acute service, obviously linking in with the community teams, but it was an acute driven service, and it was managed by Dawn as part of the trauma and orthopaedic directorate. So we were finding that the staff were working across acute and community, which was good. They were meeting the patients whilst they were in hospital, and then being part of the identification process for these patients, and then following them out into the community. And what we really wanted to do was to look at how we could use this to improve the experience. And in doing that, we were reducing our RN requirement by reducing our bed requirement in the orthopaedic ward. So we reduced our beds down, releasing some money that we would have spent on RNs, and we redirected it into this workforce. So it took a little bit of time. It wasn't without its challenges. Whilst we were using the money, but we did obviously need to provide some assurance around that. So we redirected money. We did get support almost immediately, really, from our executive board, and we were able to go ahead and start planning. working, as I say, very closely with the multidisciplinary team to make sure that we were meeting the needs of the patients in the community, and a lot of that was around regaining mobility and function. And we were finding that obviously those staff were working across, so we needed to have some sort of governance over them as well. So we were monitoring it, managing it from an acute perspective, identifying patients in our acute board rounds, and then those patients were being identified and going out. What we did look at was a maximum of 2 weeks. So we didn't really want to be going for longer term, because we needed the team to be released back to support more people. So we did have a maximum of 2 weeks. A little bit of movement on that, but generally a couple of times we got sort of caught out really with patients that had longer term needs, and because we've got some social care shortfall availability in the county, then that did cause us a bit of an issue in that we weren't able to move the patients on as we wanted to. So that did sort of have some constraints on occasions. This is just summarising really a lot of what I've just said. So it's, we had healthcare support workers, they were band 3, they were aiming to deliver a hospital level rehab care at home. It was multidisciplinary focused, 2 to 3 visits a day for an average of 2 weeks, and they were helping with and enabling patients really in the ward and at home to do what they needed to do to regain their function. And they were also providing a level of monitoring in relation to TED stocking, wearing, and supporting with exercise programmes. And one of the big things that we found in feedback from patients was that they felt really well supported, they felt confident to do things that they probably wouldn't have felt confident to do before. So we've got a patient story, which I believe is on the next slide.
I had Parkinson's, so that was an added complication. What has been key to me is that the team were available in the hospital. I got to know them when they helped me with physiotherapy. The great thing was that when I was discharged, one member of the team came out and arrived at our house with the ambulance, or at the same time as the ambulance, and was able to check that I was fully comfortable in the house, which was not the easiest of things because we live in a multi-floored property, lots of stairs. She was brilliant. Right, to me the most important thing about the whole scheme was that I was being seen regularly by people that I'd got to know in the hospital. They came at least twice a day for the first few days, and made sure not just that we were comfortable, that my wife and I were coping, but also continued the physiotherapy that we've been doing together on the wards. And that was really a great help because it encouraged me to persevere and not sort of let things slip at all. The timing of the visits was really quite flexible considering how they had to fit in other people as well, and it was a great help to us to have this continuity of care. In fact, once we finished with the home team, it was almost like a bereavement because they'd become good friends. I think it's one of the best initiatives that the hospital has done for a very long time.
So we've just provided a few pictures really just to demonstrate the support that has been provided to the patients in their own home. I think we can go on to talk about some of the challenges that we've seen throughout. So not least the rurality of the health board does obviously make it a challenge to coordinate visits in the community. We were at this point running it as a separate team, so obviously there was the potential to duplicate in terms of geography, but what we needed to do was try and look at the concept really. So looking at what we've learned, we were looking at sort of allocation of call times. We had to make sure that we did incorporate in time for travel. We looked at appropriateness of patients. So again, as I said earlier, looking at avoiding those that would go on to need long-term care. And what we did find was that we avoided some patients being referred to the reablement service that would have been previously, because they were having that sort of home support to begin with. It seemed to hasten their recovery really and reduce the need for ongoing reablement, which was obviously a benefit. Managing the caseload, our sort of overall management team were based in acute. Obviously these staff were going out into community, so it is just trying to make sure that we've got enough governance around that really. And then what we saw added benefits. So we saw in terms of our ability to manage within the orthopaedic ward, we saw the ward run much more efficiently really in terms of flow. We were holding an average of 7 virtual orthopaedic beds in the community at any given time. The feedback really from staff and patients was all positive. And we did see a significant reduction in length of stay, particularly those with fractured hips. And we did look to expand it to the general surgical group, and again trying to target patients that we would have kept in for confidence building perhaps, or to familiarise themselves. So for example, for those with newly formed stomas. And we also saw through the increased efficiency really in the management of orthopaedic patients that we weren't outlying as much into surgical beds, so obviously it had a knock-on effect on the running of the other wards as well. So the orthopaedic patients obviously were getting a better experience by being managed in the orthopaedic ward. No, really, I mean, it's just you'll see there's some compliments from patients and staff. I think it was more about, from the patients particularly, feeling enabled to do things that they wouldn't have felt able to do before really. So, and that's it, I think.